If you're waking up 2, 3, even 5 times a night to urinate, if you're standing at the toilet waiting for your stream to start, or pushing and straining just to feel like your bladder is halfway empty, I want you to know you're not alone. I see this every single week in my clinic. Men who are exhausted, frustrated, sometimes embarrassed, often wondering, is this just aging or is something actually wrong? I'm Dr. A board-certified urologist with 10 years of clinical experience, and welcome to Urology for You. Today we're having a real honest conversation about surgical options for benign prostatic hyperplasia, or BPH, what most people simply call an enlarged prostate. Here's what many people don't realize about this condition. It's incredibly common, but that doesn't mean you have to quietly suffer through it. The prostate naturally grows as men age. By the time men reach their 60, about half will have some degree of enlargement. By their 70 and 80, it's the majority, but the size alone isn't the issue. What matters is whether that growth is blocking the urethra, the tube urine flows through, and causing symptoms. Those symptoms can look different for different men. Some feel constant urgency, some go every hour, some leak a little after they finish, others wake repeatedly at night, and some can't empty well at all, leaving them with that uncomfortable heavy feeling in the lower abdomen. In clinic, I always start with the same question: how much is this affecting your quality of life? Because BPH treatment isn't just about numbers or prostate size, it's about how you feel. For many men, medications work well. Alpha blockers relax the muscle around the prostate. 5-alpha reductase inhibitors shrink it gradually over time. Some men use both. Others can't tolerate side effects like dizziness, fatigue, or changes in ejaculation. Some simply don't want to take a daily pill for years. And then there are situations where surgery becomes less optional and more necessary. If someone has repeated urinary tract infections, if there's bleeding from the prostate that keeps coming back, if the bladder is retaining urine to the point that it's affecting kidney function, if a man cannot urinate without a catheter, these are real scenarios I manage, and in those cases we move beyond medications. But surgery doesn't mean just one thing anymore. 10 years ago, the options were far fewer. Today, we have a wide spectrum from office-based, minimally invasive procedures to more traditional operations done under anesthesia. Before choosing anything, I walk patients through several key factors. How large is your prostate? Do you have what we call a median lobe, where the prostate protrudes into the bladder like a ball valve? Are you on blood thinners? How important is preserving ejaculation to you? Are you medically fit for anesthesia? That last question surprises people sometimes because not every procedure requires full anesthesia. Some can be done in the office. Let's begin with the minimally invasive therapies. One option I frequently discuss is water vapor thermal therapy, often known by its brand name Rezūm. This uses controlled steam injections to heat and destroy excess prostate tissue. The body gradually absorbs the treated tissue over weeks to months. I perform this procedure many times. It's typically done in the office with local anesthesia or light sedation. The treatment itself is quick. Each steam injection lasts only seconds. Now here's something important I tell every patient: you will not feel better immediately. In fact, for the first couple of weeks, you may feel worse. There's swelling, there can be urgency, frequency, even discomfort with urination. Most men need a catheter for several days afterward. That temporary frustration is very real. I always prepare my patients for it because improvement happens gradually as the prostate shrinks. By 3 months, most men notice meaningful improvement. Full benefit can take longer. Long-term data shows durable results for many men, though some will require additional treatment years later. Sexual function is largely preserved with this approach. Retrograde ejaculation, where semen goes backward into the bladder, is uncommon compared to more aggressive surgeries. Another minimally invasive option is the prostatic urethral lift, commonly known as UroLift. This procedure places small implants that pull prostate tissue away from the urethra, opening the channel without removing tissue. The appeal here is that sexual function is typically preserved, including ejaculation. Recovery is often quick. Some men do not even require a catheter, but it isn't ideal for every anatomy. Significant median lobes can make it more challenging, though techniques have evolved. And while symptom improvement is meaningful, retreatment rates are somewhat higher compared to more definitive surgeries. Then there's a newer option called temporary implantable natinol device therapy, sometimes referred to as IT. This involves placing a small device in the prostate for several days to reshape the tissue. It's later removed in the office. It avoids permanent implants and preserves sexual function. However, it's best suited for smaller prostates in specific anatomy. Long-term durability data is still developing. Another emerging approach uses a drug-coated balloon system designed to dilate the prostatic urethra and deliver medication to reduce regrowth. Early data is promising, but as with any newer therapy, long-term experience is still growing. Patients must use contraception temporarily afterward due to medication exposure and semen. And finally, within the minimally invasive category, there's robotic water jet therapy, often called aquablation. This uses a high-pressure saline jet under ultrasound guidance to precisely remove prostate tissue. It's performed under anesthesia and can treat larger prostates efficiently. Ejaculation preservation rates are higher than traditional surgery, but not guaranteed. Bleeding risk is somewhat higher than purely office-based procedures, and a short catheter period is expected. You might be thinking, how do I choose? That's exactly the right question, because there isn't one best surgery. There is only the best option for your anatomy, your priorities, your tolerance for risk, and your expectations. In the next part of this conversation, we're going to move into the more traditional surgical options, procedures that physically remove tissue and often provide the most dramatic improvement. We'll talk honestly about their benefits, their trade-offs, and what recovery really looks like. If this conversation is helping you so far, take a moment to like the video and subscribe to Urology for You. It helps more people find balanced, evidence-based information. And I'd love to hear from you. What symptom bothers you most? Nighttime urination, weak stream, that incomplete emptying feeling? Share in the comments. When minimally invasive therapies aren't enough, or when someone wants the highest likelihood of long-term relief in one procedure, we start discussing what many people think of as traditional prostate surgery. The most well-known of these is transurethral resection of the prostate, or TURP. This has been performed for decades and remains a gold standard for many men with moderate-sized prostates. In a TURP, we insert a camera through the urethra and shave away obstructing prostate tissue using an electrical loop. No external incisions. The channel is physically widened by removing tissue. I still perform TURP regularly. It works. Symptom improvement is usually significant and often immediate. Once the catheter is removed, urine flow improves, the bladder empties more completely. Nighttime trips often decrease. But let's talk honestly about trade-offs. Retrograde ejaculation occurs in the majority of men after TURP. Erections are typically preserved, but the direction of ejaculation changes. For some men, this is not a major concern. For others, it's very important. That conversation matters. Bleeding risk is higher than minimally invasive procedures. Though modern techniques have reduced this significantly, most men stay in the hospital overnight with continuous bladder irrigation and go home with a catheter for a short period. Another option is laser enucleation of the prostate, often referred to as HOLE. This procedure uses a laser to peel the entire inner obstructing portion of the prostate away from its outer capsule. It is incredibly effective, especially for large prostates. In fact, I often recommend it for glands that are too large for other endoscopic procedures. HOP offers excellent durability, retreatments are rare, hospital stays are typically short, bleeding risk is relatively low compared to traditional resection. However, retrograde ejaculation is again common. Temporary stress urinary incontinence can occur in a small percentage of men, but usually improves over weeks to months for extremely large prostates. Historically, over 80 to 100 G-open or robotic simple prostatectomy was once common. Today, with laser techniques like HOLE-up and aquablation, we rarely need open surgery, but it remains an option in certain complex cases. Some men ask me, why wouldn't everyone just get the biggest, most definitive surgery and be done with it? That's a fair question, because more invasive procedures carry greater risks: bleeding, anesthesia complications, longer recovery, higher likelihood of ejaculation changes, and not everyone needs that level of intervention. If someone has mild to moderate symptoms and values ejaculation preservation highly, a less invasive option might align better with their goals, even if retreatment risk is slightly higher. This is where individualized medicine becomes essential. There's also the bladder to consider. Long-standing obstruction can weaken bladder muscle over time. Even if we remove the blockage, bladder function may not fully normalize. That's why earlier intervention sometimes leads to better outcomes. And here's another misconception. Surgery does not cure prostate growth forever. The prostate can continue to change with age. However, more definitive procedures remove enough tissue that symptoms often remain controlled for many years. Recovery expectations matter. Most men can return to light activity within days to weeks, depending on the procedure. Heavy lifting is usually restricted for a few weeks. Burning with urination and intermittent blood in the urine are common during healing. Sexual activity is typically resumed after several weeks, depending on your surgeon's guidance. I always encourage patients to ask specific questions before surgery. What is my prostate size? Do I have a median lobe? What is your experience with this procedure? What are your personal complication rates? How long will I need a catheter? What are the chances I'll need another surgery in the future? Those questions are not confrontational. They are responsible. If you're finding this helpful, consider sharing it with someone who might be quietly struggling. Many men don't talk about urinary symptoms even with their partners. One of the most important things I want you to understand is that BPH management does not end with a procedure. Whether you choose medication, minimally invasive therapy, or a more definitive surgery, follow-up matters. We monitor symptom scores, we check bladder emptying. Sometimes we repeat PSA testing depending on your age and cancer screening plan. We assess how you're healing, not just physically, but in terms of quality of life. Because here's something we don't talk about enough. Sleep disruption from nighttime urination affects mood, concentration, even cardiovascular health. Chronic urinary symptoms can subtly erode confidence and intimacy. So yes, this is about your prostate, but it's also about your overall well-being. Lifestyle adjustments can support any treatment path. Limiting evening fluids if nighttime urination is severe, reducing caffeine and alcohol, which can irritate the bladder, managing constipation because a full rectum can worsen urinary symptoms, maintaining a healthy weight, staying active. These aren't cures, but they can meaningfully reduce symptom burden. Pelvic floor awareness can also help some men, especially those dealing with post-void dribbling. Learning to fully relax during urination instead of straining often improves emptying. And if you're early in your symptom journey, monitoring may be appropriate. Not every enlarged prostate requires immediate intervention. If symptoms are mild and not affecting quality of life, watchful waiting is completely reasonable. I have patients who choose surgery early because their lifestyle demands it. I have others who manage comfortably on medication for years. Neither is right or wrong. The key is shared decision. And I often sit across from a patient and say, based on your anatomy and priorities, here are 3 reasonable options. And then we talk through them together. We discuss how much ejaculation matters, how much downtime is acceptable, how strongly they want to avoid retreatment. This is not about me choosing for you. It's about guiding you with experience so you can choose confidently. If you've already had a procedure, I'd love to hear about your experience. What surprised you most? What do you wish you had known beforehand? Sharing that in the comments could help someone else. And if you're still deciding what worries you most, the catheter, sexual side effects, anesthesia, let's talk about it. On this channel, Urology for You, my goal is to bring clarity without fear, information without hype, options without pressure. An enlarged prostate is common, it is manageable, and with today's range of therapies, most men can find meaningful relief. If this video helped you understand your options more clearly, please like, subscribe, and share it. It truly helps this community grow. And remember, your urinary health is not something to ignore or quietly endure. I'm Dr. Dot. Thank you for spending this time with me. I'll see you in the next conversation.